So on behalf of McLaren Macomb, hello and welcome to this educational program on uterine fibroid symptoms and treatment. I'm your moderator, Kelly DiNardo. Today, we will be hearing from Dr. Timothy Kim. He's an OBGYN, and Dr. Jason Stenz, an interventional radiologist at McLaren Macomb. I'm sorry, Justin Stenz.
It's okay.
And at the end of this presentation, both Dr. Kim and Dr. Stenz will be answering any questions that you might have. So you just enter your questions through the chat feature and we will get those questions answered. So we will kick it off with Dr. Kim. Thanks so much for speaking with us today.
Thank you. Hello. Thanks for joining us. I'm Dr. Timothy Kim. I guess I'm representing Team OBGYN, I guess. I will present, I guess, gynecological point of view on uterine fibroids and then hand over microphone to Dr. Stenz to give us perspective on radiology point of view. Uterine fibroid or myoma is a benign tumor that arises from the muscle layer of your uterus or your womb, and is considered one of the most common benign tumor. I know my patients sort of recoil at the word tumor, but tumors are just any kind of abnormal growth, and tumors are divided into benign tumor versus malignant tumors or cancers. And the difference being that the bad things, cancers tend to grow fairly rapidly and can invade local innocent bystanding organs or even go places where it shouldn't go, like brains and bones, and cause all kinds of havoc. Benign tumors like fibroids grows, generally speaking, slowly and just exerts a local effect, in this case, bleeding and pain and sometimes reproductive issues, but nobody ever dies from fibroids. As you can see here, the fibroids are very, very common. And in fact, I think one of the more recent studies shows that you have about 90% chance for women, guys don't get fibroids, but women, you have about 90% chance of actually getting fibroids somewhere along the line in your life. It's more common in African American. We don't know why, but that's the case. Now, this cartoon is sort of a picture of your uterus. Uterus or the womb is about the size of your fist. And in this picture, feet are down this way, head is up here, left side, right side. This is a uterus with a fallopian tubes, and the tip of the uterus or the cervix is a part that sort of sticks out to the top of the vagina and acts as a conduit or a passageway between the outside world and the uterus. The uterus itself has 3 layers. The inside of the uterus is called endometrium, and this is the part that grows and sloughs off every month. And this is also where the plush lining where the pregnancy takes place when you get pregnant. The bulk of the uterus is made of this muscle. They call this myometrium. And its function obviously is to distend to allow pregnancy when time comes to contract to push the baby out. The fibroids are sort of categorized, shown here in this white mass in these pictures. They're categorized into 3 different types, so-called submucosal. These are the fibroids that grow inside the uterine womb, intramural fibroids that grow within the uterine wall, and subserosal, which is at the outside of the uterus there. So fibroids, majority of the women with fibroid, about 60% of them don't even know they have it. Women who do have symptoms have usually heavy prolonged bleeding or so-called bulk symptoms like pain, discomfort, and depends on whether it's large enough and what it's sitting on, can have urinary or bowel symptoms. Fibroids in general don't cause problem with pregnancy, but there are those cases where it can cause infertility, recurrent miscarriages, or preterm labor, preterm contractions, all kinds of problems. So how do we make the diagnosis of fibroid? Most diagnosis of fibroid is sort of suggested during the history and physical. Patient that presents with heavy periods, like they're saying, hey, Dr. Kim, I feel like I'm pregnant all the time. And when we do an exam, we will usually notice large uterus, irregular contour that suggests that patient may have a fibroid. The gold standard of diagnosis of fibroid is a pelvic ultrasound. And in this picture, patient's sort of laying on her back, legs are this way, head's this way. This is a side view of the uterus, cervix, And this black area here is what the fibroids look like. There are other modalities for diagnosis for fibroids that has very specific indication, but today, for today's topic, we'll kind of skip by that unless somebody has specific questions about that. So generally speaking, fibroids will grow throughout your life. The most recent study on that shows about 1 centimeter growth in diameter, or about ½ inch every 2.5 years or so. But even within a same individual, there's a wide variation. And these are some pictures of this. Actually, this is all taken out of the same patient, different size of fibroid. Fibroids are sometimes diagnosed during pregnancy, during ultrasound. But these incidental fibroids tend to sort of go away once the baby's out. Generally speaking, after menopause, fibroids should shrink down. In fact, menopausal women with a fibroid that continues to grow usually needs to be addressed because there can be bad things that mimics fibroid. Moving right along with the treatment. So when patient presents with fibroid, first question is, does it bother you? Do you have a problem? Patients that don't have symptoms, if the fibroid is sort of incidental findings, we basically monitor them. Patients that do have symptoms, we look at what's bothering them. Is it bleeding issues? Is it bulk issues? Obviously, how many fibroids they have and how big they are and where they are determines how we treat them. And of course, whether a patient wants to have a baby or not makes change. It makes difference in how we treat them. There's a list of medical treatment options that we're going to go through in detail. The uterine artery embolization is the area of expertise for Dr. Stenz. I'm going to just touch upon that just briefly, with Dr. Stenz's permission, that is.
Oh yeah, absolutely.
So medical therapy, medical therapy for fibroids is usually the first line of treatment. And these are birth control pills, progesterone treatments such as Depo-Provera. Birth control pills are basically the combination of estrogen and progesterone, those two hormones that your body normally makes. The idea of birth control pills is to sort of substitute worker for your ovaries. It makes your brain thinks ovaries doing its job. So your ovaries become quiescent. It's like throwing your ovaries in the freezer and replace your hormonal system, so to speak, so we can kind of manipulate how frequent or how long or how heavy your periods are. Depo-Provera, or the progesterone, same thing, is a little bit different than birth control pills. It only has one type of hormone, the progesterone, which is hormone of pregnancy. The idea being sort of fool your body into thinking that you're pregnant to hopefully slow down or stop your bleeding. I'm sure most of you guys know the side effects that comes with the pills and progesterone. And to date, there's no real clinical studies that shows that they work. In my experience, if you're lucky, it may slow down your bleeding, but obviously these are limited to small fibroids whose main issue is heavy periods. IUD, or intrauterine device, especially that has that so-called hormone IUDs, that's what IUDs look like. It's small, it fits in the palm of your hand. IUD is something we place inside the woman's uterus. It's an office procedure. IUD is meant to be a contraception. It kills sperms as they go through. But this newer IUD that has progesterone coatings on them, like Mirena, Skyla, Kyleena, again, the idea is fool your uterus into thinking that it's pregnant. In my clinical practice, we found some good results with IUD as long as fibroid is not too big and main issue is a bleeding. There's another category of medical therapy for fibroid called tranexamic acid or Listeta. These are a little bit different than the hormonal treatment. These are classified as so-called anti-fibrinolytic treatment. The idea is to sort of prevent your bodies from breaking down the clots or promote clotting. They do work, They're much easier than birth control pills because you can use that as needed. But the problem with Listera is that since it's causing your blood to clot, you have to worry about some serious complications like heart attack, stroke, and pulmonary embolism, things that could kill you. So in my clinical experience, it's sort of a desperation measures and honestly, not terribly popular in its usage. Moving on to so-called GnRH analog. These graph is pretty intimidating, but the GnRH analogs are basically medications that fools your body into thinking that you actually are menopausal. GnRH analog works at your level of your brain. It basically turns off your pituitary. And what that does is it turns off your ovaries. Your ovaries go on vacation. No more hormones stimulating your uterus. No more hormones stimulating your fibroid. GnRH analogs work. It works very well. In fact, it works too well. Most women with a fibroid who goes on this medication, it'll stop your period. It'll shrink down your fibroid. But obviously, there are some consequences of putting young women through menopause. It's not the healthiest thing. It's not something you can do for long term. There are two types of GnRH analog. There's injectable form, Lupron is the most common, most popular. And there's also oral pill form of it, depends on patient's preference. The Lupron, again, works very, very well, but you cannot use Lupron in long term because hot flushes, night sweats, patients, and sometimes their spouses are not too happy with this. And of course, there are other parts of your body that depends upon hormones, and these are your breast, your genitals, your bones, your heart, your brain. Like, for example, you'll lose quite a bit of your bone densities while you're on this kind of medication. So in clinical setting, we will use like Lupron, for example, on a patient who will present to the emergency room with heavy bleeding, with large fibroids. They are too anemic or their blood count is too low to undergo surgery. We'll put them on Lupron for 2 months, 3 months to bring the blood count back up, shrink the fibroid in preparation for hysterectomy, for example. The oral preparation is fairly new. There are newer medications like Orian, which was just approved about a year ago for treatment for fibroid, has a little bit of hormone add back. So they shut everything down, but give a little bit of hormones back to at least theoretically be able to use in a longer term. But it's fairly new, and frankly, I have not had any chance to use this medication to see how patients do with it. Now, moving on to the uterine artery embolization. Again, I will sort of touch upon this for complete sake, but as this picture shows here, these are done by interventional radiologists like Dr. Stenz. And what we do is, what he does is that we access the femoral artery through patient's groin and then put a catheter that goes all the way down to the uterine vessels. And then basically it releases little plugs that plugs up the uterine vessels. What it basically does is it basically cutting off the blood supply to the uterus, therefore starving off and killing these fibroids. But in gynecological perspective, it's probably one of the more underutilized treatment. It's much less invasive than surgeries, and it works. It works very well. In gynecological perspective, though, we sometimes see these patients within a week or two after with some pelvic pain, but these are usually self-limited. About 25% of these patients end up with a subsequent hysterectomy because sometimes fibroids will grow back. Patient selection, you cannot, well, at least theoretically, you shouldn't be doing this on patients who's considering future pregnancy for obvious reason. We don't know what happens when women get pregnant with a uterus that is devascularized or uterus that doesn't have a proper blood supply. Hysteroscopy. Anytime you see a word scopy, or scope means camera, hyst is your uterus. In hysteroscopy, what we're doing is putting a camera inside the uterus. Here's a picture of a hysteroscopy. Patient's left side, right side, floor, sky. We have a camera that goes into the vagina through the cervix, kind of pointing towards patient's head. In fact, right here, that's your left tubal ostia. That's where the left fallopian tube comes out of. Now, uterine cavity is not open like a room that you can walk into, but in this picture, we have fluid to distend the uterus, and here is your fibroid. Now, hysteroscopy and so-called hysteroscopic myomectomy, myomectomy means removal of the uterus, works very well. If they have a very discrete fibroid that we see in ultrasound, and if the patient's having a bleeding issues, we go in there with a small camera about the size of your pen, goes with a small instruments that sort of chews up on this fibroid, like taking a bite out of an apple. And we painstakingly take this bad boy and remove it from the patient's abdomen, patient's uterus. This is particularly nice fibroid just waiting to be removed, but unfortunately, not all fibroids are this easy. Some of them have half of it that sticks out and half of them that goes within the uterine wall muscles. And obviously you cannot chew up into the uterine wall because it causes a lot of bleeding. And also if you perforate through the uterus into the abdominal cavity, there are bad things like bowels and bladders and big vessels. So you can only partially amputate this fibroid at times. So it works very well for the bleeding, small number, better yet, just one fibroid. But as fibroid gets bigger or starts to get involved within the uterine wall, the effectiveness decreases. I'm sure many of you guys have heard of endometrial ablation or novissure. Sometimes we'll do concurrent endometrial ablation doing these procedures where after we remove these fibroids as much as we can, we put this instrument that, again, goes inside the uterine wall and it opens up like an umbrella, and we literally burn the inside of the uterus. It burned the endometrium, the inside lining of the uterus. And if it's done well, it'll render patient without periods. You're killing the cells that basically grows and sloughs off every month. So burning that off means no more periods or it slows down your period. But obviously, that's not compatible with future pregnancy. We call this like poor man's hysterectomy. So the hysterectomy myomectomy, this is probably the hysterectomy. Fibroid is by far the most common reason why we perform hysterectomy. Myomectomy is removal of the fibroid again, but in this sense, through the entering patient's abdomen, through the belly. Like good old days, these cases are done with a big incision, bikini cuts or up and down incision through patient's abdomen with our hands actually in the patient's abdomen. But fortunately, we don't do those procedures with open, well, rarely, I should say, we rarely do those procedures with open procedures. Most of these cases now are done through a laparoscopy or with a robotic laparoscopy. Robotic laparoscopy is sort of a subset, different specialized kind of laparoscopy. And really difference between laparoscopy and robotic laparoscopy is just some instruments that we happen to use. But in laparoscopy, what we do is here, patients laying on her back here, head this way, feet are down this way. We make a small incision around the patient's belly button, put this instruments that go inside the uterus. And then we will, in case of a hysterectomy, make a couple more incisions around the uterus, and then cut off all the blood supply around the uterus. I cannot access. Kelly, how can I access this? We got a picture of Justin kind of blocking this slide. Can we move him up here or somewhere I can access this picture?
It might just be your view because I can see the entire slide.
Okay.
Yeah.
Well, that's my bad. All right, let me see how. I don't even want to mess around with this and cause trouble. Let me try this one. Yikes, that didn't work. Try this. That's better. Sorry, I couldn't see this part. So again, going back to hysterectomy, we basically cut off all the blood supplies to the uterus and then make an incision around the cervix at the top of the vagina and deliver the whole uterus and the cervix vaginally to the outside world. And we close up the top of the vagina. Again, robotic surgeries, these kind of surgeries, obviously we have to sit by the patient's bedside, manually removing these instruments. Robotic hysterectomy, we bring a big robot that sits on top of the patient's abdomen up here and hook up very specialized instruments to the robot. And then the surgeons would go sit at the corner of the room in this little commanding pod where we look into this binocular looking things that gives me a three-dimensional picture of the abdomen as though I'm inside the patient's abdomen. And the specialized instruments that we use with robotics, difference is that it has a joint. It allows, it has a wrist that allows to do fine movements like peeling and sewing. Imagine trying to sew something with a cast on your wrist. You can do it, but it's harder. And robotic surgeries, which most of us have moved on to, allows us to it makes surgery a little bit easier, but it also allows to tackle some of the more difficult cases, bigger uterus, without actually opening the patient up. In a myomectomy cases, similar, same idea, but we go painstakingly dig out these fibroids individually and put the uterus back together. Hysterectomy, it works. I mean, it'll cure your problem. However, it's the most extensive, one of the more expensive and most invasive way to treat fibroids. Obviously, with a major surgery comes major risk for complication. Moving from laparotomy, opening the patient all the way up, to traditional laparoscopy, to now to robotic surgeries, these procedures are less invasive and there's less risk for complications, but it's still always considered to be sort of a last resort. When you do a myomectomy, when you remove the fibroids, inevitably, usually there's a uterine scar that's left behind, and the depth depends on how deep those fibroids happens to be. So you have to worry about if they were to subsequently get pregnant, most cases they'll end up with a C-section. In fact, you have to worry about them going to labor, which can cause this incision to rupture. All right, I'm going to just touch upon this so-called focused ultrasound. In focused ultrasound, the idea of it is to send this probe that generates high frequency radio wave that literally melts its fibroids. And that there are two ways about going about this business. One of them is what they call MRGFUS or MRI or magnetic resonance imaging guided focused ultrasound surgery. I don't know why they call this surgery. It's not a surgery. This is done non-invasive. There's no cut, no incision. This goes actually through your abdominal wall. It works very well, but problem is that it's very, very, very expensive. And I don't think there's any facility in the state of Michigan that actually does this procedures. And last I checked, I think closest place you can get this done is in Canada. So it's sort of really a non-issue. It's not really an option in this country. This same procedure done through laparoscopy, in other words, making an incision, actually entering the patient's abdominal wall, abdominal cavity, like shown in this picture. This is something fairly new. It's called Accessa. In this case here, here's a patient sitting, laying down, head this way. There's patient's feet that way. This is the uterus with fibroids. We put a camera inside the patient's abdomen. Again, 2 incisions, one for the ultrasound probe that shows us where the fibroid is. And this is a device that goes in and literally melts these fibroids. We have, I think, McLaren Macomb is just starting a clinical trial on this. I've never done this procedure, but it's sort of an exciting new procedure that hopefully we'll be able to utilize. So anyways, so this is sort of a general scheme as how I go about treating the fibroid. Obviously, women who, it depends upon what patient's symptoms are. Is it bleeding issues? Is it pain issues? Bulk issues? Obviously, there's a huge overlap between these two. And then obviously what patient wants to do with it in regards to having more babies or not determines how we approach this problem. What's not presented in here are, number one, the physician comfort and availability of these treatments. And just as importantly, patient preference. There are some patients who has small fibroid that's really has no symptoms or want the uterus taken out because she's not having kids. And then there are other patients who probably need hysterectomy, who just refuse to get the surgery done and comes to the emergency room every 6 months to get transfused, you know? So obviously there are many, many factors that go into treatment of fibroids. And obviously each case needs to be individualized, and you need to talk to your doctor and find out what's the best treatment is for you. And I'm going to hand off baton to Dr. Stenz. Thank you.
Very good.
Hello.
You can, yep, stop sharing your screen, Dr. Kim. There should be a stop share. Actually, I can do it. I can do it from my end.
Oh, great. Yeah. I'm actually doing it from my cell phone here. So I'm not able to share my screen.
Well, let's see. I have two screens, so I just have to. Are you able to see your slides?
Yeah, I have another screen here too, where I can look at them.
Okay.
Maybe I'll just have you kind of go through them. I just wanted to, briefly touch upon the uterine fibroid embolization or uterine artery embolization that Dr. Kim briefly touched upon. He had a great presentation. I'm not going to go in too much about fibroids. He did a great job. So I just wanted to briefly touch upon the minimally invasive treatment that we offer here at McLaren Macomb. I'm Dr. Justin Stenz. I'm the Director of Interventional Radiology here at McLaren Macomb. And, I work very closely with the OBGYN services here and provide this service of uterine artery embolization, which again, as Dr. Kim said before, is underutilized procedure for a lot of patients, I think. So basically, you want to go back to the first slide?
I'm sorry.
No, it's okay. Yeah, I'll just briefly touch upon a little bit about what Dr. Kim touched upon. So what exactly are uterine fibroids? They're very common benign tumors arising from the muscular wall of the uterus. Very common. You see them in a lot of different patients, all different ages. They range in various sizes. They can be the size of a marble, or they can be as big as a grapefruit or a softball, or even bigger sometimes. And these symptoms that they cause depend on the location, and they can range from being completely asymptomatic to very severe and debilitating. Hey, Kelly, are you able to see me?
Yes, I can see you. Yeah.
Okay, great. All right. Yeah, my screen just changed. Yeah, sorry. So our symptoms for fibroids, they vary. You can have very heavy menstrual bleeding or menorrhagia. You can have menstrual periods lasting more than a week. You can have subsequent anemia from the heavy bleeding, pelvic pressure or pain, frequent urination, difficulty emptying your bladder, constipation, low back aches, and infertility and miscarriages. You can go to the next slide. So Dr. Kim touched very extensively upon the treatment of fibroids. There's multiple different treatments from medical management to surgery and to the a minimally invasive approach that I provide. And there's advanced algorithms for treatment here, and I'll go ahead and touch upon the uterine fibroid embolization. You can go to the next slide. So uterine fibroid embolization or uterine artery embolization, we call it UFE or UAE, is a minimally invasive treatment for symptomatic fibroids. Basically, we end up treating these fibroids by making a pinhole incision in either the leg, the femoral artery, or the wrist, the radial artery, and we place a tiny catheter or tube into the artery and ultimately into the uterine arteries under X-ray guidance. So basically, once we get into the uterine arteries, we can inject a medication into the fibroids, particles that stop blood flow to the fibroids, directly from the uterine arteries. Most patients have two uterine arteries, a left one and a right one. There are some variations to it, but probably 95% of patients will have a left one and a right one. So I'll basically go into the left one and inject the medication into the fibroids that stops the blood flow. And then I'll go ahead and I'll get into the right uterine artery and then once I'm there, I'll inject the medication in the right uterine artery that stops the blood flow and shrinks the fibroids by cutting off the nutrients and blood supply. And as Dr. Kim was saying, this is a uterine sparing surgery. So you still have your uterus afterwards, and it's associated with a shorter recovery time. You can go to the next slide. So how do we know if you're a candidate for this procedure? Well, first of all, I would like you to get a thorough clinical evaluation by your OBGYN first. And then you guys would discuss this type of procedure. And then if you guys feel that, this would be an option for you, then you'll go ahead and get a referral from your OBGYN to me. And then I'll go ahead and do another clinical evaluation with you in my clinic to ensure that this is the best treatment for you. And prior to the procedure, we'd go over your symptoms, your history, and we'd also have you get some pelvic imaging. We would usually start off with an ultrasound, and that's most of the time that's all we need. Occasionally we'll get an MRI if something is indeterminate on ultrasound, where we can't really see what's going on too well, then we'll get an MRI. But usually by the time you see me, you already have an ultrasound. If you don't, then you can get one prior to our clinic evaluation. And this is basically to evaluate the fibroid location, the size, the vascularity, and it kind of helps me with my pre-procedural planning just to make sure you're a good candidate. And it also sets a baseline for follow-up after treatment, because we can kind of get progress exams and see how your fibroids are doing after treatment. Okay, you can go to the next slide. So if OBGYN, you and myself decide that this is the procedure for you, what to expect for this procedure. So I'll have you be NPO the night before. So don't eat or drink anything after midnight the night before. During the procedure, I usually do general anesthesia or moderate conscious sedation. So while we're working on you, you're really not going to remember too much. You're not going to have any pain while we're working on you. You'll be nice and sleepy. We usually don't intubate for the procedure unless it's an atypical case where we need to. And the procedure itself takes about 1 to 2 hours to perform. Sometimes it can be longer if you have a complex or variant anatomy. But like I said, most patients, probably 95% of patients, have that left uterine artery and that right uterine artery that come off pretty standardly, along the your anterior division of your internal iliac arteries. Once we do the procedure, patients generally go home later on that same day. So I usually will tell patients, this is outpatient procedure, and we plan on discharging you the same day with follow-up appointments in 2 weeks and 3 months. Occasionally, depending on how extensive the fibroids are and how everything goes, occasionally we'll admit you overnight for a night for pain control and kind of medical management and just to watch it. But most of the patients go home that same day. As far as the procedure goes, there's no scalpels, sutures, or scars, just that pinhole incision in your groin near the femoral artery or your wrist. I like to give patients realistic expectations for this procedure. When we inject that medication into the fibroids, those particles into the fibroids to shut off their blood supply, patients will have at least some pain and cramping after the procedure as those fibroids die off. It is a minimally invasive procedure. It's associated with low complication risk, but you will have some pain as those fibroids die off. But this pain is controlled, and it's controlled with oral medications, and the pain significantly decreases after the first day. So what I like to tell patients is that we're going to go ahead and do this procedure. We're gonna finish in a couple hours. We're gonna keep you in the hospital and give you some fluids and some pain medication. Likely discharge you home the same day. You're gonna get home and you're gonna have some cramping, and you're gonna have some pelvic pain. It's gonna be a little uncomfortable, but after about midnight, 2 a.m., the pain really improves, and then the next day it's not too bad. That's the majority of patients. They'll say, oh yeah, last night I was kind of feeling it, but this morning I feel okay. And, I can go ahead and my pain will be controlled with the Motrin type medication. And usually it's a Motrin type medication that will prescribe, and that anti-inflammatory will really help you out over the next couple of days. And then usually after about 5 to 7 days afterwards, you're pretty much back to normal for most patients. Now, I have had patients where they didn't really have any pain at all afterwards. And, they had their symptoms improve significantly, and they were success stories. And I've had other patients where they had real significant pain, but that pain always kind of decreases after the first day and continues to get better. You can go to the next slide. So this is just a fluoroscopic image that I took on one of the patients. As you can see, this was from a femoral approach. We have a catheter or a microcatheter in the left uterine artery. We're injecting some contrast dye under X-ray guidance, and we can kind of see all those blood vessels. Those are those squiggly lines, the black squiggly lines surrounding that big fibroid in the fundus of the uterus there. And, I can tell that I'm directly in the uterine artery under X-ray guidance, and I'm seeing a real good picture of the blood vessels supplying the fibroid. And so I know I'm in a good place where I can go ahead and inject that medication and shut the blood flow off to that fibroid. And right when I'm in that spot, I'll go ahead and inject until I get good stasis of the blood vessels to the fibroid. And then I'll go ahead and go into the other side. You can go to the next slide. And as Dr. Kim was saying, we get real good results with this type of procedure. At the end of the day, about 9 out of 10 women are happy with their overall results. And we call that a success story. So probably a 90% chance of it working. If your symptoms are bleeding, heavy periods, menorrhagia, anemia, we get very good results with this procedure. So nearly 100% of women will have improvement in bleeding. So if you have bleeding symptoms, this is a very good procedure for those patients. And the control with the bleeding will actually happen usually right away. Within the first week or so, you'll have improvements in the bleeding. And the other symptoms will kind of improve over the next couple weeks. So that's kind of the minimally invasive uterine artery embolization procedure in a nutshell. And obviously this is just one part of the treatment algorithm for fibroids. But again, I think it's an underutilized treatment, especially considering fibroids can be very debilitating and cause a lot of distress in a lot of patients. And I know a lot of patients don't even know about this type of procedure. So I really try to promote this type of procedure in the community to help them out. And that's my little spiel on the UFE.
Great. some really good information from both of you. So I appreciate that. I am going to unmute you, Dr. Kim. So I'm going to start with Dr. Kim. Is there anything that you can do to prevent fibroids?
No, simply no. Yeah, I
Very-
think it just happens like taxes.
Unfortunately, right?
Unfortunately. Right.
Yeah. Dr.
Actually, I mean, there have been some studies on like diet and things like that to sort of at least modify or prevent rapid growth of the fibroids there. Those kind of studies are really hard to interpret, and there are some sites on the internet, for example, talk about different kind of diet that helps with minimizing or at least attenuating some of the symptoms there. I don't think that's real, but I think we just don't know yet. How's that for answer?
Very good. Yeah. Dr. Stenz, are there any restrictions after embolization?
Yes. So it kind of depends on the approach that we do. If I do a femoral approach where I go into the groin, then I'll have you lay flat for 4 hours after the procedure. And because we don't want to get a bruise or any bleeding at the puncture site in the upper leg. If we go from the wrist, then you'll have to wear a little band on your wrist. And then as far as restrictions after the procedure, it's basically activity as tolerated once you leave. I like to have you drink a lot of fluids. In fact, I like to encourage you to kind of move around and not stay bedbound for too long, because if you stay bedbound, then you have a risk for other issues like blood clots in the legs and stuff like that. So our main thing is kind of getting the pain controlled with that Motrin type medication afterwards, and that's usually very successful. And once that pain is controlled, then as far as restrictions go, it's just kind of activity as tolerated, drink a lot of fluids, and try to stay otherwise healthy.
I think it's going to be for Dr. Kim. Do fibroids interfere with fertility or increase risk during pregnancy?
Answer is yes. There's a bit of a controversy on this because fibroids are so fairly common. So if a patient that presents with, let's say, infertility, when you happen to see, say, a fibroid on ultrasound, it doesn't always correlate to causation. So in other words, there are a lot of patients that walk around with fibroids that have 6 children without problems. But then there are those cases where the fibroids especially the fibroids that are growing within the uterine cavity, that depends on its location, could cause implantation of pregnancy there. So in those cases, we will, it's like say a patient with 4 miscarriages, we do an ultrasound, had a fibroid that's occupying the uterine cavity. We do go in there and the hysteroscopy, go in there with a camera inside the uterus and remove those fibroids. And in those cases, most of those women will go on and do very well. In fact, they will get pregnant and they do well. So, but the 2 issues. Number 1, fibroids are so common. There's so many women that walks around with it that do perfectly well. And number 2, things like infertility, recurrent miscarriages have lists this long on what causes it. So sometimes it could be just sort of a coincidence. That's why, generally speaking, most of us hesitate to do surgery for those kind of indications. But in my experience, those women who need to undergo those kind of surgeries do very well again, do have pretty good results afterwards.
I think this question might be for Dr. Stenz. If you've already had a myomectomy, right, then could you still qualify for the procedure?
Yeah. Yep. And, a lot of patients have had myomectomies and they still have, symptoms from fibroids. And like we talked about, fibroids can kind of be anywhere within the uterus, near the endometrial canal, or kind of outside the uterus. And if they've had a myomectomy, usually it's kind of like a subserosal fibroid, kind of outside the uterus, where they can take it out. But some of the fibroids kind of in the uterus and near the endometrium, they're kind of harder to remove surgically. And so that's where kind of the uterine artery embolization would come in, and they would kind of get those fibroids. So yeah, it's not a problem. We have a lot of patients that have had myomectomies in the past and come in for, additional treatment with uterine artery embolization.
Dr. Kim, you may have already answered part of this question in your last response. Should a surgery for the removal of a fibroid be recommended if one has two little fibroids, especially if they are young and hoping to have kids in the future?
Generally speaking, no. I mean, if you were to go and remove all the fibroids that we see in our patients, we'll be doing that 24/7, right? So sort of prophylactically going in there, removing the fibroids is generally not recommended. Again, it's because it's so common, and the causation, fibroids causing infertility or future infertility, you cannot make that connection without really, unless this particular patient had, recurrent miscarriages and the fibroids are within the uterine cavity, then again, those are the cases where we'll consider removing them. But just incidental fibroids and young women, we do not treat them usually. Yeah.
Very good. And Dr. Stenz, how long after embolization does it usually take for fibroids to start to shrink?
That's a good question. Yeah. So usually they kind of start shrinking right away. If you have bleeding symptoms, that actually improves right away. As far as the fibroids go, it's a little bit variable, but usually at around 3 to 6 months, the fibroids will be about half the size. So generally what we see is we'll get a follow-up ultrasound at like 3 or 6 months. And if you had like an 8-centimeter fibroid, usually that fibroid is probably around 4 centimeters at that time. And they'll kind of continue to shrink as we move forward, as the patient gets older. And plus also, some of these patients are near menopause as well. So that will kind of have a synergistic effect, and those fibroids will continue to shrink. So probably about half the size in 3 to 6 months usually.
Dr. Kim, so what is your best advice for patients? When is enough? When do you need to seek treatment if you have fibroids?
You know what? Things like treatment for fibroids are usually patient driven. Like say, if I do a pap smear on you, you find like cervical cancer or something, doctors will recommend treatment regimen. Fibroid patients are again will usually present with a problem. In other words, if I do an ultrasound on patient and find a fibroid and patient has no symptoms, we would not really recommend treatment. And there are patients who have fibroids that probably needs treatment that prefers not to, because again, nobody dies from fibroids, right? Fibroids are really quality of life issues. And there's this patient coming in and say, hey, Dr. I small fibroids that's minimally bothersome but want to be treated. And there are others with a big fibroids that probably needs to be treated. They don't want to be treated for whatever the reason. So these treatment for fibroids are elective in a sense, not elective as in, breast augmentation, but elective in a sense that it's driven by how much it bothers a patient. And obviously we'll put our input into it when the patient presents, but it's really driven by patient's perception of how bothersome the problem really is.
Very good. Any closing thoughts from either of you? That was our last question.
I actually had a question for Dr. Kim.
Sure.
I think in your slide you mentioned that after the uterine artery embolization, sometimes the patient will sometimes the patient will come in for a hysterectomy ultimately afterwards.
Right.
Do you find the hysterectomy is much easier after a uterine artery embolization as far as decreased risk of bleeding and kind of decreased size of the fibroids and uterus in general?
Definitely. The urinary embolization does basically same thing like the long-term Lupron does. It shrinks down
Sure.
the size of the fibroid, number of the fibroids, and probably more importantly, the vascularity of the fibroid. It's less blood supply goes into it, which makes surgery much easier in a sense that, you know, smaller mass to remove, less bleeding. Yeah, definitely.
Sure.
Yeah.
Okay.
And I think, honestly, between you and me, I think if the gynecologist did urinary embolization, which we shouldn't, I think it'd be done more often. Not in our perspective, but in a certain sense, from the patient's point of view. You know, patients will come in and say, "Hey, what are the treatment options?" They don't really want to be referred out for the problem that.
Sure. Yeah. And that's
yeah. You know what I mean? So it's sometimes hard to even convince our patients. Say, well, go see your radiologist and go to the hospital and get this done. There's certain, especially for field of OB/GYN, it's very intimate.
Sure, yeah.
Field, and I think there's some patient hesitancy in this as well. At least initially when I used to present UAA.
Right.
You know, yeah. But I think we maybe need to almost push that as an option to, you know, as a legit option for those patients that are probably would benefit from the most, you know?
Right. Yeah, I totally agree.
Yep. Look, we agreed on something there. Yeah. That's pretty good.
How about you, Dr. Kim? Any closing thoughts or comments?
Me? I mean, Dr. Stenz? Oh, me?
Yeah.
No,
Yeah.
I'm good.
Very good. Dr. Stenz?
Yeah.
Good.
I'm good.
All right. Well, thank you both so much. This has been really very great information for everyone here. So I appreciate you both spending some time with us today, and thank everybody that joined us.
Thanks for having us, Kelly.
Yeah, thank
Thank
you.
you. Thank you, Kelly.
Yeah, thank you.
All right. Take care.
You too.